Good day. I'm Brian Hoffland, President of Research to Prevent Blindness. Welcome to RPB's Lunch and Learn, Eye on Dry AMD. Research to Prevent Blindness is the leading nonprofit organization supporting eye research directed at the prevention, treatment, or eradication of all diseases that damage and destroy sight. RPB was founded in 1960, and over our 60-year history, we have awarded more than $387 million in research grants to the most talented vision scientists at the nation's leading medical schools. As a result, RPB has been associated with nearly every major breakthrough in the understanding and treatment of vision loss. In today's educational session, you will hear from two RPB-supported, talented scientists about dry AMD causes, impact, and cutting-edge research. One of our speakers, Dr. Janet Sunnis, received an RPB Special Scholar Award and an RPB Physician Scientist Award earlier in her career. The second speaker, Dr. Christine Curzio, has received several RPB awards, including an initial RPB Career Development Award. I want to give a warm thank you to all the generous supporters of RPB who make our work possible. The importance of supporting medical research has never been so apparent. We thank you for your partnership in supporting innovative vision research to ensure that new breakthroughs are possible. If you have not supported RPB, please consider doing so to help make sure we are able to continue to support these breakthroughs. But getting back to today's session, let me introduce our moderator. Federico Grossi, MD, PhD, is Chief Medical Officer at Apellis Pharmaceuticals. Apellis develops transformative therapies for people living with a broad range of debilitating diseases. Apellis treatments are designed to control complement or the complement cascade, part of the body's immune system. Dr. Grossi has worked for Apellis since 2010, and prior to that, he served as Clinical Research Director for Potentia Pharmaceuticals. Dr. Grossi received his medical degree from the University of Cordoba in Argentina and his PhD degree in physiology from the University of Louisville, Kentucky. Following his postgraduate training in surgery, Dr. Grossi joined the Plastic Surgery Research Laboratory at the University of Louisville. He developed expertise in microsurgery and composite tissue transplantation. He was a crucial member of the Louisville face transplant team, whose publications are now considered hallmark publications in this field. Dr. Grossi will introduce our two speakers for today and will moderate the question and answer session at the end. So Dr. Grossi, please take it away.
Thank you, Brian. And I also want to thank the presenters, Research to Prevent Blindness, for organizing the event and all attendees. So as you said, our topic today is dry age-related macular degeneration. This topic is very important, not only because of the number of people it affects, but also the impact it has on vision and quality of life. AMD, dry and wet, is the leading cause of permanent vision loss in people over the age of 65. And the risk of developing AMD increases exponentially with age. Over 1 million people have GA in the United States and about 5 million people globally. And while there are multiple effective treatments for wet AMD, there are not currently approved treatments for GA. The cause of GA is thought to be multifactorial, with numerous environmental and genetic factors. And the dysregulation of the complement cascade plays a pivotal role in the development of and progression of dry AMD. And that is what makes this topic especially important for us at Apellis. We hypothesized on the involvement of complement in AMD more than 17 years ago, even before the publications on the seminal papers on the associations between genetic polymorphism and AMD were released. And that included several complement components. We were the first group to test a complement inhibitor in AMD. And after all, these many years of research, we were able to demonstrate that there is a biological effect of complement inhibition in GA. And then this is not only important for appellees, but also for the scientific community and patients, and it adds to the body of evidence on the biology of dry AMD and put us one step closer to a potential treatment for GA. So now let me introduce Dr. Janet Sanes. Dr. Janet Sanes is an ophthalmologist specializing in low vision rehabilitation and in retinal disease. She's on the faculty of the Wilmer Eye Institute for 20 years, where she conducted a large study on the progression of advanced dry macular degeneration, which has served as the basis for designing clinical trials for this condition. Since 2005, she has been medical director of the Hoover Low Vision Rehabilitation Service at the Greater Baltimore Medical Center. She's also a professor of ophthalmology at the University of Maryland School of Medicine. Dr. Sanes is a world expert on dry macular degeneration. She has won a number of national and international awards for her research in macular degeneration and in low vision intervention. She's also a member of the Medical Advisory Board of Maryland's Motor Vehicle Administration to try to find safe ways to enable people with low vision to continue driving. She received funding from Research to Prevent Blindness at a time when this was very important for her career. In 1999, she received the RPB James S. Adams Special Scholar Award, and in 2003, she received the RPB Physician Scientist Award. Janet, the floor is yours.
Thank you very much. It's a pleasure to share the podium with Federico and Christine, both of whom I've known for many years. And it's a particular honor to speak for the Research to Prevent Blindness Association, because as Federico said, I have really benefited from them. And it was at a time in my career when I really needed the support, and it enabled me to continue my work in dry macular degeneration. From 1992 to 2000, I conducted an NIH-funded natural history study of advanced macular degeneration, which is called geographic atrophy. This study was done before people were really interested in geographic atrophy, and really has served as the basis for designing most clinical trials for this condition. We followed 139 patients for about 4 years with a variety of clinical measures, visual function measures, questionnaires, et cetera. So we really got a comprehensive sense of what geographic atrophy is and what it does to people. I wanted to point out also, I'm the chair of the Data Safety Monitoring Board for the Lineage trial, which is a trial of using stem cells for geographic atrophy. I wanted to point out first that the macula is only a very small part of the retina. If you look at the picture at the left, and I should point out that I'm going to describe everything on the screen. So if you can't see it, you're not really losing anything. The picture on the left shows the whole retina, and you can see that the macular region, which is the region that's circled, is only a very small area of that. And that points out the fact that when someone has macular degeneration, it affects the central vision. In other words, it affects your ability to read, to see fine print, to recognize faces, and so forth. It generally does not affect mobility, walking around, or those things. Peripheral vision, which is not affected in age-related macular degeneration, is what is necessary, like I said, for getting around. But what that means is that people look like they're walking comfortably, they look like they're seeing people, but in fact, they're not seeing the person's face because they cannot see in the center. Christine is going to talk much more about this, but I just wanted to point out to start off with, in the retina, there are cells called the photoreceptors, which are the cells that catch the light. They sense the light, so to speak, and they will send their message to nerve cells and out of the eye into the brain. The layer underneath the retina is called the retinal pigment epithelium, and that serves to nurture the photoreceptors and also to serve as a barrier between the underlying blood supply and the photoreceptors. Its function is very important for survival of the photoreceptors, and macular degeneration generally affects this first. These cells don't work as well. They may allow blood vessels to come through, or they may die off, and that impacts the vision. So dry AMD is a large spectrum of disease, and it's very confusing for patients because someone can say, I have dry macular degeneration, and to one person that means that they have maybe a little difficulty at night or just a little decrease in vision. To another person, it means they're legally blind. And the fact that somebody has a little bit of macular degeneration doesn't mean necessarily that they're going to go on and lose their central vision. And it's been very complicated for understanding this. So the top row here shows a normal retina. And I included what's called OCT images, which are like a cross-section of the retina. So it shows us really what's going on, because if you have macular degeneration, they'll constantly be doing this kind of measure. So I wanted to show it. In the middle, there's, you can see there's a little bump in that bright line. That's a little drusen, a little small yellowish spot that develops under the retina. And then on the bottom, there's a situation where there's many large drusen. You can see in the left, there are all these yellow spots. And in the right, it's very bumpy there. There are many areas where there are these deposits present. I'm going to focus today mainly on the advanced form of dry macular degeneration, otherwise known as geographic atrophy, because it's like a continent on the sea of the retina. It's very discrete. You can see in the bottom left image that the geographic atrophy, which I've outlined, is much lighter and very discrete, very demarcated from the rest of the retina. There are a number of ways that we measure them, that we assess them. The one on the top left is again an OCT, where you can see specifically where the photoreceptors are gone. And then there are some other methods that are used very often. I don't have a slide. Okay, good. I'm just going to pass over this because Christine is going to talk about it. Dry AMD involves deposits under the retina and ultimately a loss of the cells underneath the retina and the overlying photoreceptor, so that blind area is developed. In wet macular degeneration, there are abnormal blood vessels that grow through and they bleed and leak and scar, and that's what causes the visual loss in wet macular degeneration. What's the difference between them? First of all, the wet macular degeneration, as I said, involves these abnormal vessels growing. Secondly, wet macular degeneration generally starts in the dead center of the macula, which is a small area of the retina. And the fovea is what we call it. It's at the dead center, where what you need for really seeing things clearly. Geographic atrophy, in contrast, generally starts outside the center, near the center, but outside the center, so that central vision can be preserved for a long time, as you'll see. Wet macular degeneration is now treatable with injections, and as Federico said, currently there is no proven treatment no accepted treatment for geographic atrophy. But it's important to understand that all wet macular degeneration really starts from dry macular degeneration. In other words, it's the degeneration of those cells under the retina that leads to either of those conditions. Geographic atrophy is present in about 3.5% of people who are 75 and older, and it increases to about 25% of people over 90. It's more common in white people. Smoking increases the risk. They estimate that there are currently about 1.8 million people in the United States who have geographic atrophy, and it's projected to go to 5.4 million by 2050 with the aging of the population. This slide shows a classic progression of geographic atrophy over a 10-year period. The upper left panel just shows when the patient had some early drusen present and some pigmentary change and had no loss of vision. Then a couple of areas of atrophy developed above. And then to the right, you see that those areas coalesced and enlarged. Now we start getting some atrophy in the bottom of the image, below the fovea, and then that coalesces into a horseshoe. The bottom panel shows that this horseshoe now coalesces into an area of atrophy surrounding the center. Now, atrophy means there's blind spots. So the patient sees in the center and then has blind spot around it. And finally, they lose the center of vision and they become legally blind. So for this reason, visual acuity itself doesn't fully capture the impact of geographic atrophy. You have people who can read small letters on a letter chart, but they have trouble reading a whole word, or they have trouble seeing a full face because a face or a word does not fit into that little spared region in the center. And one thing I use to help people understand what they have is I use what's called face fields. I tell them to look at my face and look at my nose and tell me what they see. Is there part of my face that's missing or blurry? This is a patient who had what I showed in the previous slide, like a ring of blind spots surrounding the center. And she said, I see your nostrils, but I can't see the rest of your face. So that really gives us a sense of what happens with these people and why they can't recognize faces, even though they can read little small print. There's great symmetry between the eyes. This is what's called autofluorescence imaging, and it has the right eyes are on the left and the left eyes are to the right, but you can see within each row that the atrophy, which is the black areas, look very similar. So that as time goes on, the patient is losing vision in both eyes. It's not just one eye. And for eyes that have geographic atrophy and good vision at baseline, in my study, 25% became legally blind at 4 years. So it's really a significant impact on the vision, even though it's not an acute event. It's a gradual event, but it causes significant vision loss. And one thing that's very impacted by geographic atrophy and by dry macular degeneration in general is the ability to see in dim illumination. So the top left shows a regular visual acuity chart that we use. And then what I've done in our study is we put like a moderate sunglass basically over one eye of the patient, then we have them read the chart again. A person of the same age who doesn't have age-related macular degeneration just worsens by about 2 lines when you make it dimmer. But a person who has geographic atrophy, even when they still have good acuity, they can see small letters, they worsen by an average of 5 lines. And there are some of them who can see the small letters at the bottom of the chart, but can't even see the top letters when you put them in dim illumination. So it's really a significant impact on night vision, on dim vision. Patients report most prominently difficulties reading small print and identifying faces, seeing in dim illumination, and driving is a difficulty for them. And these tend to get worse over time as the disease worsens. Now there's treatment for intermediate dry macular degeneration, but what's important to know is that it's treatment in the sense that it reduces the risk of getting wet macular degeneration by about 29%. It does not have any effect on the risk of getting advanced dry macular degeneration, that is geographic atrophy, or on geographic atrophy progression. And treatment for geographic atrophy, there is no medical or surgical treatment at the present time, but I'm going to discuss Apellis and other things shortly, but there is low vision intervention. Now, I wear a few different hats. I'm a medical retina specialist, and as such, I treat and have treated for many years people with macular degeneration as a retina specialist, but I'm also a low vision specialist. And for geographic atrophy in particular, there's much, much more we can do with low vision intervention currently than we can do medically or surgically. Start advancing here. Okay. It's important to know that, and it's a wonderful thing to know, that there are mainstream devices such as a smartphone or a tablet that really help people significantly and that can serve as tremendous benefits for them. For one thing, you can use them as text to speech, or you can use speech to get it to work. You could say, hey, Siri, call this and this number. It can serve as a GPS, helping people not only with driving, but with walking around. It enables a person to read handwriting, to recognize currency, and so forth. It's wonderful, wonderful to have this as something that's mainstream, and a person does not look like they're using something abnormal if they're looking at their cell phone or their tablet, because everybody's doing that. But there are specialized optical and video devices for macular degeneration. On the top, you see some magnifiers, and these fall into the category of optical magnifiers, that is using lenses to magnify things, and video devices, which are like the camera on your cell phone, where what the text gets projected onto a screen and you can change it from white on black to black on white. and you can enlarge things and do many other manipulations. There's also, at the bottom right, you see somebody wearing telescopes that help you see at distance, and the person in the middle is using one of what hopefully in the future will be many virtual reality type devices to try to magnify things and increase contrast. Besides magnification, there are a number of things like improving lighting and improving contrast that can make a tremendous difference to people who have geographic atrophy. But one thing that's really important, so you need things bigger, you need things bolder, but one thing you really need is to be aware of the boulder, B-O-U-L-D-E-R, that is what looks like a rock, a blind spot in your vision. If somebody saw a black splotch where they had a blind spot, in a sense, it would be much easier because they'd say, oh, there's my blind spot, I have to look out of the way. But the brain doesn't do that. The brain tries to make sort of a unified picture. And so the person doesn't understand really, why are things going in and out? Where is it? I can't see. And this is what I thought was a very good description. It's actually in a different disease. It's glaucoma, but it's the same principle. So in the top photograph, you see that there's a photo of a street, there's a pedestrian crossing, there's a car there. This person has a blind spot to the left. So when they look at this image, they did not see the person, they did not see the car, and they're not aware that they missed them. So you can imagine that that's really a significant issue, and it's a significant issue for reading and other things. So one thing we focus on, and I work a lot with an occupational therapist who's very good at this, is to teach people where their blind spots are and how you have to compensate for them. Okay, so there are a number of clinical trials for geographic atrophy now. Apellis, which Federico has been involved in and headed for many years, deals with what's called the complement system. That's a system that controls inflammation. And their study has shown that their drug, which is something that has to be injected into the eye, slows down the rate of enlargement of geographic atrophy. And there's a second company also that has shown similar things. People are doing retinal pigment epithelial transplantations. In other words, they take stem cells and they make them turn into these retinal pigment epithelial cells, which are the ones that get sick and die in macular degeneration, and they transplant new ones. And there's some exciting evidence from the lineage trial that maybe actually it can rejuvenate the retina to a certain extent. There are some studies that use vitamin A variants because vitamin A, as you know, is very important for the eye. And if you sort of cut down normal vitamin A, it reduces the amount of stuff that's accumulating in the drusen, those deposits that may lead to the degeneration. There are people working on the mitochondria, which is sort of like the energy engines in the eye that seem to help to keep cells alive. And people are working on gene therapies that might help.
Dr. Sunnis, you should wrap up in the next 2 minutes, please.
Yep. Apart from that, there's treatment for geographic atrophy in terms of how do you make the vision better. So in geographic atrophy, the layers that take the stimulus and bring it back to the brain are okay. It's the layers that sense the light that are abnormal. So there are efforts now to try to see if we put an electronic sensor to substitute for these light-catching cells, that will signal the other cells to bring the message to the brain, and maybe we can restore vision. So that's in its early stages. And I always conclude with this because it's important to know, and I try to tell every patient about it. About 20 to 30% of patients who have macular degeneration and other disorders get what we call visual hallucinations. It's called the Charles Bonnet syndrome. They see people or patterns or flowers or animals, or somebody sees sheet music, etc. You can see all different kinds of things just because the eye is trying to compensate for vision. It's not getting from the brain, is trying to compensate for input. It's not getting from the eye. It's critical, in my opinion, to tell people about it because we just had someone this morning, actually, she said, a 95-year-old woman, she said, I never told anybody about this because I thought they would think I was crazy. She sees people. So I try to tell everyone about it. So I hope this has given you a little flavor of dry macular degeneration, especially the advanced forms, and I look forward to answering your questions after. Thanks for your attention.
Now, let me introduce Dr. Christine Curcio. Dr. Christine Curcio is the White McKee Endowed Professor of Ophthalmology and Visual Sciences at the University of Alabama at Birmingham School of Medicine. She collaborates with innovative eye banks to investigate human retinal neuroscience, aging, and age-related macular degeneration. She has focused on pathobiology, especially drusen and outer retinal degeneration, and validation of clinical retinal imaging technology, including optical coherence tomography, fundus autofluorescence, and adaptive optics-assisted outer retina imaging. Her maps of the human photoreceptor layers provided the basis for rod-mediated dark adaptometry as a functional test for AMD. Since 1984, research resulting in about 200 peer-reviewed articles and more than 250 invited presentations has been funded by the National Institutes of Health, foundations, and industry. She serves on the editorial boards of Investigative Ophthalmology and Visual Science and Retina. She was awarded the 2002 inaugural Roger H. Johnson Prize for Macular Degeneration Research, the 2014 Ludwig von Salman Prize, and the 2020 Research to Prevent Blindness David F. Weeks Award for Excellence in MD Research. Dr. Curcio provides histology to the classification of atrophy group, a clinical international consensus group that is defining OCT-based imaging endpoints for MD clinical trials. Dr. Curcio, please, you can start your presentation. Thank you.
Thank you very much for the introduction. Thank you, RPB, for arranging this event and for the support over the years. And it's a great honor to be here with Federico and Janet on the same symposium. Thank you all for coming today. These are my funding sources. And this is my conclusion. The outer retinal cells, layers, and regions are the XYZ of AMD, and they benefit from precision imaging by way of OCT, this technology that you see behind me. RPE cells, which you heard mentioned, are central to AMD pathophysiology, and they're uniquely visible in OCT over time, which is T. And molecular characteristic, or characterization, or M, as the fifth dimension of AMD, shows loss of normal function, gain of abnormal function, suggestive of epithelial mesenchyme transition, or EMT. So we might consider that drugs that target EMT known from cancer might be repurposed to benefit AMD patients. We see the fundus view like we saw from Dr. Sunnis, and here's the three-dimensional coordinate system. And the two coordinates, X and Y, are what we see in the fundus view, and OCT is Z, providing the cross-section of the retinal layers. This is shown here. This bright line is the retinal pigment epithelium. This technology, OCT, uses reflections of near-infrared light to produce depth-resolved, comprehensive, non-invasive, quick images of the retina and the supporting vasculature. I first saw this in Europe in 2007 and thought everything we can see under a microscope in my lab can now be seen in the clinic. This is fantastic. So there's been great progress since 2008 when it was commercialized, signal averaging for detail, eye tracking for precise follow-up over time. And this is the important thing, time, seeing what happens over time. We see multimodal imaging to confirm in different technologies. The anti-VEGF for neovascular AMD led to many images of eyes at risk as patients came in every month to be treated. And now there's even more resolution in the axial plane of all the outer retinal layers. And you can see that bright layer there, the RPE. And we need that resolution because if you look at the left, the yellow frame shows a close-up of a B scan, and there are 9 distinct layers of biology in 100 microns of vertical height. That's in the height of a human hair, and you can see all the layers in there. The photoreceptors are up at the top. The gray layer in the middle are the retinal pigment epithelial cells, and they support support the photoreceptors above and the vasculature on the bottom. And you can see the two bars on either side showing the bright and dark bands by OCT. So the idea that if we know that if we consider OCT a microscope, we can ask what's being stained. And here we want to know what is reflective. And the idea that organelles were reflective came from some landmark work by Wilson Foster a number of years ago. And they abide by the physics principle called me scattering, which is the scattering of light over from lipid water interfaces, just like you get on the membranes of organelles. And we can see this very clearly for RPE melanosomes. Here's a cartoon of the outer segments of photoreceptors, and the little fingers below are the apical processes of the RPE with black dots in them. And the black dots are the melanosomes. That has a melanin pigment that gives the RPE its name. Here's a histological section under a microscope of a monkey eye, and you can see all the melanosomes standing up vertically at the top of the cell. This is a dramatic feature called melanosome translocation. In frogs and fishes, the melanosomes actually race out to the top of the apical processes when the light comes on. And you can see that in this movie of OCT, how the reflectivity changes. And this was direct proof that the melanosomes are reflective. Well, in the cells that Wilson and Foster studied, they didn't have melanosomes, but they had lots of other organelles like lysosomes and mitochondria, and they're all reflective. And the RPE has loads of them. We published last year an atlas of 17 perifoveal RPE cells that were reconstructed by volumetric electron microscopy at 50 nanometer intervals, and all the organelles could be counted. We found over 1,400 organelles that are capable of generating reflectivity in each cell. And the melanosomes that I just showed you are actually the minority of the reflectors. The majority reflectors are the mitochondria, which were over 700 per cell, and lipofuscin and melanoma lipofuscin, which are also sources of autofluorescence signal. So that no wonder the RPE is so reflective, and that gives us a fantastic opportunity. Now I'm going to pick up another thread here to show some of our other work. I do what I call population-based eye pathology, meaning I work with eye banks to get specimens with disease. I'm very fortunate to work with the Advancing Sight Network here in Birmingham, which is the fastest eye bank in the US for tissue recovery time, and they've also been in the top 5 for transplantable corneas. So they have lots of tissues. And in a 14-year period, 95 to 2009, I collected over 900 pairs of donor eyes at under 4 hours post-mortem, which is very short. And in 2011, with Foundation and NIH support, I was able to create the Project Macula website, which is a high-resolution histology online resource to inform clinical OCT imaging. And it consisted of systematic review and photo documentation, 150,000 layer thicknesses. At the same time, I was approached by Bailey Freund in New York City, who asked me to provide histology of any of his clinic patients who died and became eye donors. And he and the other physicians at Vitreous Retina Macula Consultants of New York are some of the provide some of the best clinical imaging anywhere. And so this was a great opportunity to correlate the in vivo imaging of OCT with postmortem histology. And the common method from both the website creation and the clinical pathologic correlation of specific patients was linking the histology to B scans. And you can see that here. We have an eye holder that we put a donor eye into it and put it right into a spectralis. It looks into the OCT, and we can record B scans. And then we are able to take all the clinical B scans shown here on the right and match histology sections to it. So we can seek clinically identified features. We maintain the topography of the macula over a large area. And it allowed us to test an important hypothesis about what is the RPE doing in atrophy, in the steps before atrophy. We want to know what's going on before atrophy so we can stop it or prevent it. And we worked under the hypothesis that the RPE exhibits stereotypic stress responses that can be defined, quantified, and followed in life, that those bright cells would show us what they were doing, and we could deduce what stressors they were suffering from the behavior of the cells. And so we began a systematic survey of RPE morphologic phenotypes in 53 late AMD eyes. This is a bit like deducing evolution from the fossil record. And we found a number of morphologies ranging from age normal up here on the upper left to totally atrophic down on the bottom right. And we found fully pigmented RPE cells scattered across the atrophic area. We found some shedding material, but these are the ones I really want to focus on. They're the ones that are sitting on top of the layer here. They look like they're sloughed. And then we saw RPE cells fully pigmented up in the retina, and where they normally don't go. And then we saw others that actually dove under the layer. And we quantified these and hypothesized that there were two major pathways of RPE fate in AMD. And one was this shedding type, where the cells dropped their granules into the underlying tissues. But here's the one that I want to focus on, where cells actually left the layer and they migrated into the retina. And that was a substantial fraction of the cells that we saw. And the layer breaks up. It's like a sidewalk with cracks in it. It breaks up. Cells actually dive under the layer and head on out of the atrophic area, and perhaps adding to the expansion of atrophy. So I'm going to pick up another thread now of research done by my friend and colleague Vas Sada, who's been a real proponent of what OCT could do for us. And he came up with the 4 biomarkers risk calculator for AMD progression. And the way this works is that each eye of a patient gets a point for one of the OCT features I'm going to show you. And the fellow eye, if it has advanced disease, has 4 points. And at the end, a patient can have somewhere up to 8 points, which indicates what their risk is. So here are the risk factors. One is how much drusen, simply the volume of it. Another are hyperreflective, hyporeflective, non-reflective areas in the middle of drusen, subretinal drusenoid deposits down at the bottom. There's a whole other layer of lesions. And this one right here, hyperreflective foci. These are bright dots up in the retina. Now, as I said, these can be followed over time. And here is a clinical trial data set, which are highly prized because these are randomized patients. They're followed in a systematic way over time. And it turns out that the big score among the biomarkers are hyperreflective foci, bright spots in the retina. This is another look at the same Harvard trial data set. You can see that there are lots of bright spots up in the retina. They were mapped here by their height up in the retina, both for progression, for neovascularization, and for atrophy. And finally, Dr. Sato is very kind to share this with me. These are from an even bigger patient population, over 1,300 eyes. And once again, the hyperreflective foci, the bright dots up in the retina, are the ones that are confer a tremendous amount of risk for progression. Well, so what are these? Okay. Well, we showed that there were pigmented cells up in the retina that seemed to come from the RPE, and using histology of eyes that we had imaged with OCT, we could correlate that reflectivity up in the retina to fully pigmented nucleated cells. So these appeared to come from the RPE. And if you look here at the behavior of the cells, you can see at 0 months, there's a little bit of roughening up of the RPE layer. 2 months later, there's a bright spot up in the retina, and 3 months later, it's larger. So we can see how the RPE layer, which is normally intact, is disturbed before something appears in the retina right above it. So it looks like the RPE is migrating out of the layer. So one of the huge missing pieces in AMD was how drusen, the characteristic extracellular lesions, would lead to atrophy. And this is where OCT really was a big help. And you can see here that we were able to plot with OCT scans the volume of this large Druze complex, that big yellow thing in the color fundus photograph, and you can see a rising phase and a collapsing phase. Well, how does that look on the individual B scans? You can see that here. At 0 months, the RPE layer, that bright band, looks smooth. Even though it's on top of a big Druze, it doesn't look that unhappy. But at 7 months, you can see a little ruffling up, and cells are starting to leave the layer. At 17 months, there are a number up in the retina. At 23 months now, there's light shining down through because the layer is starting to break up as the cells die or leave. And finally, 34 months, it's collapsing, and 41 months is a spot of atrophy. So this is a cycle of growth and collapse. And our interpretation of this, because we have a very strong model of how RPE make drusen, is this. And that's a whole other topic which I will not discuss today. RPE constitutively produces material that normally exits to the circulation, but it's impaired from transit out to the circulation by changes in the vasculature, Brooks membrane in the chora capillaris. And so this big druze collapses because production by the RPE is discontinued as it leaves or dies off the layer, and the clearing mechanisms in the vasculature catch up, and that's why the druze is cleared, and then you have atrophy. So this is a recent study in which we defined a particular type of hyperreflective foci called RPE plume because it has a distinct curved trajectory in OCT. We found 4 different phenotypes. The most dramatic one is shown there in panel D, the vitelliform type. You can see it's thick at the bottom and it tracks the paths of the fibers in the retina. We followed plume morphology over many months, and many of these resolved. They did not lead to atrophy, about 40%. So HRF is an indicator, it's not a predictor. We don't know for certain that you're going to get atrophy right in this spot. And here is what we could find of an RPE plume in a donor eye. We could see the reflective area. We could find it again under the microscope. And here's a whole trail of RPE cells crossing the retina. They've left the layer, they're crossing the retina, and where they're going is to the vessels of the retina. Here's a group of them glommed onto one of the capillaries in the retina. So the RPE leaves the layer and it's going into the retina to contact the deep capillary plexus. And this is what happens in a form of neovascularization called type 3 or interretinal neovascularization. And we think it's a big hypoxia-driven event. The RPE needs lots of oxygen, and if it's not getting it from the vessels underneath it like it's supposed to, it goes into the retina looking for something better.
Dr. Kurzer, you should wrap up in the next 2 minutes, please.
Okay, well then I'll try to make this very brief. Okay, this is some immunohistochemistry showing how the RPE gains and loses function as it leaves the layer. So CD68 is a protein that is in the lysosome of macrophages, and it's used to diagnose macrophages, but it turns out that those RPE cells in the layer are all very CD68 positive. So are the cells in the atrophic zone where they're all breaking up. So are the subducted cells. They're all expressing this marker. Okay, and there's one cell on top of the layer and it has the marker, and individual cells in the intact layer are starting to express this abnormal marker. We saw the same results for another marker, indicating that the RPE is now expressing markers of an immune cell. On the other hand, the RPE is supposed to be dealing with vitamin A derivatives. You heard that in the last talk. And one of them is RPE 65. And the cells up in the retina no longer express RPE 65. They're not handling retinoids anymore. The ones that are sitting just on top of the layer are not doing it. The ones that are underneath the layer, they don't express it either. And you can, neither are the ones in the atrophic area. And we get a similar result for another retinoid marker. So the RPE is now is changing its character. It's no longer expressing markers indicating it's handling vitamin A like it's supposed to, but as soon as it becomes abnormal, even in the intact layer, it's starting to act like an immune cell. So we're interpreting this as widespread molecular transdifferentiation of RPE that had not been appreciated before, and no one might have looked for it except for those hyperreflective foci. So this is just a summary cartoon to show how that might work. All the abnormal cells, including the HRF, are affected. And so we think the hyperreflective foci are simply an indicator of widespread change. Other cells may also contribute to these hyperreflective spots like microglia, and they, in fact, we know that they're there in neovascular disease. Now, why is all this happening? It's because the RPE has very high, and the retina has high oxygen and glucose utilization. It needs its vessels. And in AMD, the choroid vasculature thins, there's loss of capillaries, all that vascular system behind the retina, and you get growth of deposits between the vasculature and the cells. So we think the whole thing is driven by hypoxia, lack of oxygen. So the RPE transdifferentiation may be a sign of epithelial mesenchyme transition, because cells in an epithelium like the RPE, when they leave the layer, they usually die. But if they can escape cell death by undergoing this transition, EMT, it's very well known from cancer. You can see it down there. It's associated with specific proteins that are markers. And this is a process that's very well studied in cancer, because tumors of epithelial origin undergo epithelial mesenchyme transition, in which cells lose their polarity, their differentiation, and they gain migratory and invasive properties. And we think this is what the RPE is doing as precursor to atrophy. And this is not surprising that this should happen, because the retina and the tumors have very similar metabolisms. It's called the Warburg effect. It's been known for over 100 years, and it's because the retina renews photoreceptor outer segments every day, and tumors are fast growing. So they actually have a lot of metabolism in common. And so
Dr. Kersey, I'm sorry, but
yeah.
we need to move to the Q&A session now.
Okay, well, I'll come back to my speculations about all this in the Q&A.
Thank you so much, both of you. Wonderful presentations. We have no questions on the queue yet, so I'm gonna ask a question myself. First to Janet. You talk a little bit about the symmetry, Janet, between the two eyes. How important is this fellow eye in the patients that you have bilateral GA, for studies and to be used as a control? We know that, potentially many diseases, there can be this fellow eye effect. So can you talk a little bit more about that?
I think that it's a fantastic thing in terms of clinical trials, because if you're doing a trial where, for example, you're injecting something in one eye and not treating the other eye, the fellow eye, the eye not being treated, is an excellent control for a comparison for the eye that was treated. So from that point of view, I think it's a very important and very informative thing that the Food and Drug Administration does not really accept that as the main criterion, the main outcome measure, because they're interested in safety of the whole person, and you couldn't get that if you're just comparing one eye to another. But in one of my papers, I speculate that if there were a significant difference between the growth rates in the two eyes, you would just need about 30 patients to see that if you compare one eye to the other. So I feel like if there's this clinical trial that does not present that information, you have to be suspect.
Thank you very much. Christine, you talk about shedding and migration, and the migrating cells being the hyper-reflective voice that we see. Can we pick on imaging the shedding, right? Or we're not there yet. And then with that, how we correlate, because you have a really good imaging and histology and also function by histology, correlation. Now, what about vision, right? Is there any way to correlate that to actually, function test by vision? So kind of two questions in there, but I'm more interested in, imaging, histology, function.
Okay, yeah, thank you very much. The shedding cells that you asked about, we actually have a clinical pathologic correlation on that, because the RPE organelles are shed down into the basal laminar deposit, and there are clumps of it there. And we had a case where the basal laminar deposit was thick enough and the clumps were big enough and you could see them. So in the right circumstances, in the right patients, you can see that phenotype as well. And particularly as new high resolution OCT comes online, I think that'll be quite possible. Now, your question about function, I've been collaborating with Cynthia Owsley for many years on issues of dark adaptation. So rod-mediated dark adaptation is a functional test that follows on what Janet just said about vision in dim light being difficult for AMD patients. And we showed that hyperreflective foci are associated with slowed rod-mediated dark adaptation. And because we think they're basically tapping the same thing, which is a problem with the chorea capillaris, Brooks membrane, the buildup of deposits, and that's what slows vitamin A and other transfer to the photoreceptors and causes them to leave to go in the retina. So we think we're actually seeing two different aspects of the same thing.
All right. Janet, you talk about most treatment or solutions, and for now all we have are the devices basically, and no pharmacotherapies just yet. But you do mention what is in in development. Do you have a view on what you find more promising on the development side based on what you know? On the drugs.
And I think, I'm sorry?
Yeah, on the drugs, I think you were on mute. Yep.
Yeah, and I think Christine would probably agree with me that despite the fact that she's been able to look at the progression of geographic atrophy, it's still really a mystery in terms of what is actually turning it on. She was mentioning ischemia, the lack of circulation. Some people feel the retinal pigment epithelial cells themselves are getting destroyed. So many people have looked at complement, which is again a part of the inflammatory cycle, partly because there's a strong correlation in people who have a genetic variant of a complement factor to macular degeneration. But in my opinion, I still cannot connect the dots and say, okay, this is exactly how it happened. So I find it very difficult to speculate on which will be best because we don't really know enough about the pathophysiology yet.
Yeah, exactly. I think I have to agree with that. And it's hard to tell, at what point, coming from intermediate into the conversion to either late or the progression of late. And to your point, any inflammatory process may be really the end effector, right, of the final destruction versus an initiating factor.
But the other issue is that maybe we're doing it too late. Some people would say
Exactly.
that once you have geographic atrophy, that's not the time you should be treating. You should be treating when you see these deposits that Christine was talking about, when you see the drusen, but not at the stage where it's already happened.
Exactly. So, Christine, mentioned ischemia a lot. Is neovascular resection actually, because you see a lot of patients with GA that have occult CMV that is not showing up, is not exudated. Is that trying to protect the retina and the patients that perhaps do not develop CMV to try to oxygenate more, then develop GA? And then the second piece to that, when you see the drusen forming, you say it disappears. Does it always disappear? You have GA without that collapsing of the drusen?
Oh, I'll answer the last question first. That that drusen can collapse and leave the outer retina intact. I would say it's probably the minority of cases, but I mean, they're dynamic. And that's one of the reasons why drusen volume alone is not such a good outcome measure, because of the variability, and you have to get past the variability. But it's not, a drus can collapse or let's call it resorb and leave an intact looking layer. Now about the neovascularization, you know, if I hadn't packed in too many slides, I would have gotten to the one where I said that to me, it's a disease of aging. And if you look at what is the biggest age effect, it's the loss of the choroid capillaris. Because the RPE, at least in the macula, maintains its cell number, and the photoreceptors are losing 30% of the rods. And I interpret that as meaning the photoreceptors are further away from the vasculature than the RPE is. So the RPE is doing okay, and the photoreceptors are taking a hit. So the most, I can explain the most pieces of AMD pathophysiology by proposing it as a vascular originating disease, because I can pile up drusen. Once I get drusen, I can have peroxidized lipids and inflammatory disease. So to me, there's this floor of microangiopathy, and that's the beginning of it. Now, the treatments I can come up with are not so much directed towards the choroid capillaris, but that's how I explain it. That's why I come up with the vascular origin. The question about neovascularization, Bailey Freund, my collaborator, will tell you how patients are curing their own atrophy by having a non-exudative type 1 neovascularization under the RPE. And we published a case, was 10 years of good vision, because there was this big neovascular net keeping the RPE alive.
Yeah, and a totally related question came out, and you, if you can answer really short, is the hypoxia hypothesis accounts for the foveal sparing in GA, because you have, you know, better oxygenation. Really quick, so I can go to.
My hypothesis is for foveal sparing is that the Mueller glia and all that xanthophyll of carotenoid is keeping the cones alive.
Right.
We're, Dr. Grossi, we're actually at the end of our hour, and what I'd like to do, we have a few questions in the Q&A. What I'd like to do is, just to respect people's time, to close it out, but then we can go on, we can run on. If people want to stay on, we can ask these last few questions that are popping up. But I just want to say thank you to you, Dr. Grossi, for being such a knowledgeable and expert moderator. We appreciate that very much. And I want to thank Dr. Sanas for, I think, maybe perhaps the clearest overview I've ever heard of AMD geographic atrophy. So thank you for that. And Dr. Curzio, thank you for, you know, giving us such an expert and penetrating glimpse into cutting edge science and how we might be able to really have very early diagnosis and intervene at an earlier stage. And I want to thank everybody who you know, linked into this session and participated, and also for your questions, some of which we'll get to in a minute or two. But and I also thank you for your support of research to prevent blindness. There's going to be a recording of this event that we will send out to all participants next week. So you will have that, and you can, you know, listen to these presentations again. I think that might be helpful for many people. And again, just thank you for all. But now, Federico, we are at our point, but if you would just go on and ask these last questions, I think that would be great.
Yep, we have.
I just wanted to say one thing before you start.
Yes.
To the last question, I think foveal sparing is the mysterious aspect of macular degeneration, of atrophic macular disease. It's present in other diseases, which are with death of the retinal pigment epithelium. And if that could somehow be harnessed, if that could be understood better, it could really, and if you could make that more active, you'd preserve a lot more. There's the retinal pigment epithelial is different in the center. The structure of the cells is different. There is more circulation, but there's also less lipofuscin, and there are a whole variety of things. But if there were some chemical or other way of intervening to enhance that, it would make a tremendous difference.
Thank you. Janet, a question for you. You said that each eye shows the same retinal degeneration as the other, if I understood correctly. What then is the significance, if any, of this difference in visual field visible to each eye?
Do they say visual field or visual acuity?
Well, visual field. So I guess the question goes to, is the retinal degeneration exactly the same eye, and functionally, when it comes to visual field, will be exactly the same on both eyes? I would say no, but I'll let you answer the question, right? It's not, it's symmetrical maybe on size, but not necessarily on shape and whatnot. So,
well, sometimes it's advantageous in the sense that it's mirror image of one another. So in other words, one person can have a C-shaped area of atrophy in one eye and a reverse C shape, and then they sort of complement each other so you get more vision. But the thing that's really makes it difficult is that the size of the atrophy and the rate of the growth of the atrophy is very symmetric between eyes, but the visual acuity can be very, very different, because if one eye has a little area of sparing, the other eye doesn't, they're going to have dramatically different visual acuities.
Thank you so much, Janet. A question for Dr. Cuscio. While hypoxia is the initiator of EMT-like features and migration of the RPE cells towards the inner retina vessels, would you be able to comment on microglia and other immune cells, macrophages, the contributions of those other cells?
Sure. That's an excellent question, because we know that hyperreflective foci in neovascular AMD and in other conditions like diabetic retinopathy include cells that stain for macrophage markers. So we think that it's very likely that they're macrophages, microglia, or both. What's less clear we also know that microglia come to the retina as the photoreceptors die. What's less clear is what the involvement of those cells are early on in disease. Macrophages definitely come in from the choroid as part of type 1 neovascularization. I think there's an expectation from mouse models where there's a lot of microglia in the subretinal space in aged animals. We don't see this in humans. The outer retinal immune system in human and mice seems to be quite different in that regard. We have data that we're preparing for publication on that.
Thank you so much. That was the last question. Somebody else thanks you for the excellent presentation. So with that, I want to thank you both again. Thank Research for Prevent Blindness for organizing the events, and everybody who attended. I think it was a great meeting and great presentation. So thank you so much, and hope everybody have a great afternoon.
And Dr. Grossi, thank you again. Thank you again to you. And I just thank our participants again. Really some great questions. Thank you. Thank you all.